Immunotherapies have led to unprecedented response rates in multiple myeloma, both with bispecific antibodies and CAR T-cell therapy. We have now 5 immunotherapy compounds that are FDA approved in the United States, 2 CAR Ts, ide-cel and cilta-cel, and 3 bispecifics, teclistamab, elranatamab, and talquetamab. And many more of these constructs and agents are currently in advanced clinical development. So it becomes very important to recognize immunologically mediated side effects with these therapies, and these therapies do have unique side effects, and learn how to manage them. So in the short term, the most common side effects include cytokine release syndrome, ICANS like neurotoxicity, which is immune effector cell associated neurotoxicity syndrome, HLH like toxicity, and cytopenias and infections. And these cytopenias and infections can continue over the long term. The more delayed neurotoxicities that happen over the next few weeks are also important, and they're particularly seen with certain CAR T constructs like cilta-cel. We're also seeing some target-specific toxicities that can happen over a few weeks after start, including with GPRC5D, including cerebellar neurotoxicity seen with CAR T, and skin and taste changes seen more commonly with bispecifics. And then very important, in the very late toxicity, we have second primary malignancies, which can happen due to a variety of reasons. They can happen because of prior therapy exposure, they can happen due to decreased immune surveillance, and very importantly, although it's very rare, is CAR T insertional mutagenesis in T cells leading to T cell malignancy. Of course, we are all very attuned to it now that the FDA has launched an investigation into all CAR T cell leading to T cell malignancy. And so what we see is a rate of secondary primary cancers, hematologic malignancy, 1% with ide-cel, and a little bit more with cilta-cel, probably due to survival time bias. We've only seen one reported case of a T-cell malignancy with cilta-cel in the public domain, and that's an online-only publication at this year's ASH meeting with a T-cell lymphoma seen after cilta-cel in the CARTITUDE-4 trial. I'll also point out that it's very important to know about diagnosing cytokine release syndrome and early management of cytokine release syndrome with tocilizumab and with steroids, and starting second-line agents like anakinra early. And while it's not part of the FDA label, tocilizumab has just as important role to play in management of CRS with bispecifics as it has with CAR T. So one message I want providers who take care of these patients to take home is use tocilizumab with bispecifics as well. And even though it might not be part of the label, it's very effective, decreases recurrent cytokine release syndrome.